Tonight's discussant is Dr. Charu Agarwal, the Leslie Heisler Professor of Lung Cancer Medicine from UPenn. And Charu, I'll go ahead and turn it over to you.
Thank you, Charles. Thank you, everyone, for joining us tonight. We'll talk a little bit about perioperative therapy in early-stage lung cancer and implications for molecular testing. As many of you know, a lot has changed in this space. Would love to just talk about a few of the changes with really an eye towards molecular testing. So we'll get started. As you all know, targeted therapy has led to meaningful improvements in overall survival in metastatic non-small cell lung cancer. And if you just look across the board, all the way on the left with our chemotherapy alone histology agnostic clinical trials back in the early 2000s, where median overall survival was only 8 months. We now have median overall survival over 3 years with drugs targeting both EGFR as well as ALK. And you can see here that we've made significant improvements, but this is based on detection of molecular alterations. Personalized therapy is based in lung cancer on the recognition or the understanding that there are different subsets of lung cancer that can behave differently. They occur in about 50% of all patients with non-squamous non-small cell lung cancer. In the middle, you will see that overall survival is actually associated with comprehensiveness as well as availability of next-generation gene sequencing prior to first-line treatment. And then finally, overall survival benefit from targeted therapy is actually lost if targeted therapy is never delivered. So it's really important if we talk about metastatic setting first to identify these patients. Tissue testing has been our gold standard, but there have been several barriers for molecular testing. These begin with anxiety and stigma. Patients want to get started on treatment quickly. Inertia bias, also defined as, just increasing pressure on oncologists to make sure that treatment is started fast. And, sometimes five more clicks in the EMR is too many clicks to actually order another test. We talked about tissue availability, hospital resources, as well as reimbursement and cost effectiveness may be other barriers. So if we really look at the issue of tissue or QNS, we and others have shown that you can actually use plasma ctDNA very effectively to actually identify patients with actionable genomic alterations. If you find somebody with an actionable alteration, you don't necessarily have to wait for tissue sequencing any longer. We showed this in a large analysis at our institution where using tissue alone, we were able to detect a mutation about 20% of the time, but this increased with tissue and plasma detection to 36% when we layered in plasma for patients with metastatic lung cancer. There's also barriers in terms of urgency to start treatment. I'm sure many of you face this in clinic. Patients come in and they want to get started yesterday. You try and talk to them about biomarker testing, but then they say to you, but can't you just give me Keytruda or Opdivo, whatever they saw on TV that day. So we started this clinical trial at Penn hypothesizing that incorporation of earlier liquid biopsy at the time of diagnostic biopsy will actually reduce the time to treat. So here you have our workflow. Patient with a possible diagnosis of stage 4 lung cancer comes in, usually sees either our interventional radiologist or a pulmonologist, undergoes diagnostic sequencing. Our usual algorithm is that they would meet with medical oncology who would send off ctDNA. However, we moved this up front where, where they had 2 tubes of blood drawn for patients with suspected lung cancer. And what we found was that more patients with lung cancer with plasma genotyping performed at the time of initial diagnostic biopsy received an actual treatment recommendation during the first oncology visit. You can see 74% of the time. And then if you look at the time to treatment, compared to our historical cohort, patients that had prospectively collected biopsy, liquid biopsy at the same time as their diagnostic biopsy were able to start treatment in 10 days or so. Those with an actionable mutation were able to start it even sooner, with a median of about 10 days. It's very important to recognize that while molecular testing is important in metastatic non-small cell lung cancer, there's a role for molecular testing even in early stage lung cancer. We know that there's availability of not just targeted agents, but also immunotherapy now, which we'll talk about. It's important to identify the right patients for the right treatment. It becomes challenging in the early stage setting, even at an institution like ours, even though we have reflex testing pathways in place. Testing for early stage resected lung cancer may not occur uniformly. There is a 14-day rule regarding next generation gene sequencing testing. I'm sure many of you face that, and we can talk about that. And then medical oncologists do ensure completeness in all patients with stage 4, but we are just trying to move our practice so that all patients with early stage lung cancer can see medical oncology so that we can ensure completeness of molecular testing.